Hello and welcome. Thank you for joining us today. My name is Michele Dunlap, and as president and co-founder of TTAG, I'm pleased to open up this webinar for today titled Debunking the Stigma about Coprofenoema. This discussion comes at a particularly important moment. Recent reactions surrounding the BAFTA award ceremony have highlighted how easily misunderstanding can arise and how quickly it can contribute to the stigmatization of less common features of Tourette syndrome, such as coprofenoema. Today, we aim to challenge those misconceptions with accurate information, context, and lived understanding. We will also be exploring the broader impact that stigma and misrepresentation can have on quality of life, an aspect that is too often overlooked, yet central to the experiences of individuals and families impacted by Tourette syndrome. It is a true privilege to welcome our guest speaker, Andrea E. Cavanna. Professor Cavanna is a consultant to behavioral neurology in Birmingham and an associate professor in neuropsychiatry at the University of Birmingham. With many years of clinical and research experience focused on Tourette syndrome and tic disorders, he has been a leading voice in advancing diagnosis, treatment, and long-term support, always with a strong emphasis on evidence-based care and improving quality of life. We are delighted that he could join us today and share his expertise. Please note that the presentation will last 45 minutes, followed by a 15-minute question and answer session. So kindly please use the chat to submit your questions, which will be answered once Professor Cavanna has concluded his talk. Thank you once again for being here. And now over to you, Professor Cavanna.
Thank you very much, Michelle. And I hope that you can hear me well, despite the accent. That's something I can't change. I tried for 20 years, but I failed miserably. And I hope you can still understand and see the slides, which I've put full screen and shared. So yes, I'll try to entertain you for 40 minutes or so before the interactive session with the questions and answers. And the topic is quite timely, as you rightly said. I will touch on the BAFTA incident later on in the slides, and I will also leave my disclosures towards the end. So I try to leave the best at the end to keep people interest alive. Okay. So coprofenoema, this term straight from the ancient Greek, which means dirty stuff. Okay, coprofenoema, coprolalia and copropraxia. Involuntary swearing as a tic, coprolalia, and involuntary production of rude gestures as a tics in copropraxia. I took this leaflet from the Tourette's Action UK, where I'm based, and you see that the second point that the colleagues wished to put across to all GPs, so primary care, general practitioner, is exactly about the coprolalia. They say about 90% of cases do not, in capital, have involuntary swearing. That already tells you something about the prejudice, okay, or the biased, skewed view that lay people, but even primary care practitioners can have about Tourette syndrome, right? So why? Well, a bit of history is essential to understand the link between coprofenoema and Tourette syndrome. I start with a story. I'll tell you the story of the cursing Marquise. I'm sure many of you already know about her. French noblewoman, first seen by a doctor, Jean-Marc Itard, French doctor, in 1825. So we are before Gilles de la Tourette. Tourette syndrome didn't exist at the time. And she was causing a kind of a scandal in the high society society of Paris, French high society at the time. Why? Because she, you see here, barked repeated words and uttered offensive words and obscene sayings. Itard was quite clever because he understood that these behaviors, so easily mistaken for misbehavior, were in fact a medical condition. She couldn't help it. So she had the tics, but nobody really knew about tics at the time, and she had these manifestations, and Itard published case as a case report, we would call it nowadays, arguing that this was a medical condition. What happened then? Jean-Martin Charcot, the master, read Itard case report, summoned Gilles de la Tourette, his favorite pupil, and asked him to write up no longer a single case report, but an entire case series. No less than 9 cases resembling the Marquise, the cursing Marquise. And this is Gilles de la Tourette's own paper, The Birth of Tourette Syndrome, 1885, 60 years later. Case number 1 is the redescription of the Marquise, and the other 8 cases shared the same features. It's in French. It was published in the Revue Neurologique, which was at the time one of the most important journals, scientific journals in neurology worldwide. Okay, still existing, of course. We are still talking about this historical character, the cursing Marquise. You see here the historian of medicine and neurology, Howard Kushner, detailing the obscene words, shit, fucking pig, see in French here listed. And she was recently identified. We know that she was called Ernestine, actually, thanks to the work of our dear colleague Olivier Waluzinski. Was able to identify her and published this paper again recently, Revue Neurologique, again, telling the story of this character. She was actually born 22nd of August 1800, and she died in 1884, which is 1 year before Gilles de la Tourette's paper. So she didn't live long enough, not quite long enough, to read her case published again in the most famous paper by Gilles de la Tourette, which gives the name to her condition. This is Olivier. If you're interested in the roots, the beginning, the history behind Tourette syndrome, this is the best book ever produced, best biography of Gilles de la Tourette by him, Oxford University Press, 2018. And as I just mentioned, this sort of period of time from 1883 actually to 1885 was quite eventful for our hero, for Georges Gilles de la Tourette. In 1883, another woman, not Ernestine, not the cursing Marquise, who was, as we've just heard, quite old at the time, and she was going to die the following year. But another woman called Rose Kemper tried to assassinate him. She attended his consulting room, hiding a gun in her bag, and shot him, but he was wounded only superficially. A year later, Ernestine died, the cursing Marquise died, and a year later, upon his master's request, upon Charcot's request, Gilles de la Tourette published the paper that gave the name to the condition. This is, by the way, the 1883 sort of crime episode from Le Pays Illustré. And if you want to see the characters I've mentioned so far, this is the most famous painting of all neurology and psychiatry, depicting our hero, as I said, sitting in the first row, Gilles de la Tourette, in front of the master, Jean-Martin Charcot. It's a clinical demonstration at the Salpêtrière Hospital in Paris. Still there, painting, very big painting, large. You find it at a university, no longer at the hospital. What happened next? Well, we've just seen that swearing was there in the very first description of Tourette syndrome, and that in a way marked the destiny of the condition. Not long after Gilles de la Tourette's paper, you see that father of modern psychiatry, Freud, took an interest in this condition. And you see, he contributed to the notion of the psychological origin of Tourette syndrome, because he interpreted the coprolalia, the swearing tic, as a result of a self-fulfilling fear of being unable to repress the utterance of obscene words. Okay, so subconscious, in a way, conversion of repressed urges into this involuntary swearing. So it was not the best start, if you want, for tic disorders, because they were very much linked to a psychodynamic interpretation, to psychological processes, and Freud steered the discourse away from the underlying neurobiology. And some of his followers followed the footsteps of the master. Think of the Hungarian psychoanalyst Sándor Ferenczi, for instance, according to whom motor tics were the result of repressed urges to masturbate in the little child. Okay, so trying to blame parents for repressive education, for causing, all psychological, psychodynamic narratives. But then, as you can see, in the 50s, the pendulum began to swing back to an organic view of the cause of Tourette syndrome, mainly based on a large epidemiological study. So Tourette was no longer seen as a rare, bizarre medical curiosity with people swearing and so on, but seen as a relatively common movement disorders with multiple manifestations, including among the more extreme ones also the Coprofenoema. And then, most importantly, in the 60s, the first dopamine blocking agent, it was a haloperidol actually, was shown to be effective. So that again, in a way, reinforced the biological underpinning of Tourette syndrome. So that's it for this. But I felt it was important to understand why we are talking about swearing, because it doesn't happen with many other neurological or even psychiatric conditions that people with that diagnosis are kind of expected to swear in the lay discourse. Now, if we look at the evidence about scientific evidence in the modern era about coprofenomena in people with Tourette syndrome, what do we see? Let's start with the early modern literature, where in the 90s, as we've just seen, larger clinical studies were conducted and published, mainly North America and Europe. And they started looking at the prevalence. How many people who have a diagnosis of Tourette's also report coprolalia? You see that back then, most reports indicated a prevalence quite high, above 30%. And in this study, in younger patients, actually, the authors first suggested that the widely recognized figures for coprolalia might have been overestimated. They say we only found 8% in our study who swore as a tic. So first signs that the received narrative of Tourette syndrome might have needed a revision, an update. And already in the early literature, you find your lists of swear words in different languages. You see, in the interest of time, I don't spell them out one by one. We are still in the 90s, and these authors, what they did was a review of what had been published before, starting from Gilles de la Tourette's actually case series. You see 1885, 9 pages. This is Gilles de la Tourette's own first paper. They actually cited the English translation by Chris Gates and Clawons, okay? And as we have seen, initially the percentages were very high, but you see that they start to drop, with time. Still, the received sort of narrative in the 90s was 30%, starting to change. A review article, Singer, coprolalia and other coprofenoema, end of the 90s, neurologic clinics of North America, the usual list of possible swear words in the different languages. And then we reach the more recent literature. We are in our century now. And as you know, the first multi-center international collaborative studies were realized. Roger Freeman led on an important collaborative effort, which resulted in a few very influential publications, because you see, there were 15 sites involved in 7 countries. So it's really almost like a worldwide study in specialist clinics, combining, collating data from experts worldwide. They found coprolalia occurred at some point lifetime in 19% of males and almost 15% of females. Okay, so we are well below 30%. And what about copropraxia? For the first time, we have large, reliable data about having to produce root gestures as complex motor tics. And you see that the prevalence is even lower. We're talking about 1 in 20 patients. And these are patients seen in specialist clinics. So by definition, the more complex, the more severe ones. Okay. This is again Freeman's review of what had been written and published before about the prevalence of both coprolalia and copropraxia. You see, as we said, the tendency towards a decrease as studies got bigger and more accurate. We are in London, 2011, paper published in the JNMP, led by Mary Robertson. I'm sure you're all familiar with her. And a large, again, cohort of patients, large sample size. You see that there are 654 files of patients with Tourette syndrome of all ages. We retrospectively reviewed them. We found that vast majority, 90%, had at least one comorbid psychiatric disorder, the usual suspects, the way ADHD, OCD, and so on. And what about coprolalia, copropraxia? Well, we looked at that. Specialist clinic, again, with a referral bias, we found 30%, exactly 30% of coprolalia and 20% with copropraxia from specialist clinic in the United Kingdom. What about the other countries? Well, there are similar papers, single center specialist Tourette syndrome clinic in other countries. They took one from our colleague Kerstin Müller-Fahl in Hanover. There are 1,032 patients, and we have hair data which are very close to the London ones. You see, coprolalia 24%, slightly lower, and 15.5% copropraxia. large data sets from specialist clinics. Even when we narrow our focus down to the more severe end of the spectrum, seen as we said, in the specialist clinics, then we find that the maximum, the upper limit is 30%, and it tends to be slightly lower than that. So research increased. Papers just focusing on coprolalia started to appear. This is from our group 13 years ago. And we started to learn more about not only the prevalence of the coprofenomena, but also the clinical correlates. You see, the age at onset, for instance. This is a paper study from Poland, and they looked at when patients first report the onset of coprofenomena. You see that there can be an early peak, primary school age, which is a few years, not many, but a few years after the average age at onset of tics in general. As you know, tics tend to start with simple motor tics. The most common tic at onset is eye blinking. The average age at onset for these simple motor tics is 5, 6 years. And you see that a few years later, there's already initial peak in the development of. So the ones who are meant to develop it often develop it early on, okay? And then there's another peak, the main peak, which is in the middle teenage years. And that has a kind of posed some challenges recently, since there has been an increase, an unprecedented increase in reports of functional tic-like behaviors. Okay, so these are different from the neurodevelopmental tics in Tourette syndrome, and the functional tics often actually start in teenage years rather than at the beginning of primary school, and often present with more extreme manifestations at onset, including coprofenomen. We'll come back to it in a moment. So the second peak might overlap to some extent with the onset of coprofenomena in people who have functional tic-like behaviors. Other evidence, well, I would say arguably one of the best papers published so far, most comprehensive reviews on coprofenomena in Tourette's, but not just in Tourette's, in general, was published by Veit, Rösner, Alex Munchau, their group, and it was out in 2021 in Neuroscience and Biobehavioral Reviews. They confirm the figures from the largest studies, England, Germany, 20 to 30% of all patients with Tourette's. Then they provide more details. Basically, the studies they base their figures on are the ones that I mentioned so far, and they break down the findings about coprolalia and copropraxia, acknowledging that, you see the first line here, there is almost no research investigating copropraxia alone or in combination with verbal swear. So there's much less known about copropraxia, okay? Which is a shame, because as we will see in a moment, these manifestations often also have cultural variations, okay? Do they matter? Well, they do. They do. You see, they are associated with worse individual and family function, quite predictably, understandably. Is the particular nature, antisocial sort of nature of these tics lead to worse interpersonal function, people who have. You see, there's another finding, that it's people who have more severe tics in general who are more likely to also develop these coprofenomena. So they tend to be on top of already marked tic severity. Sum it up, again, very recent paper, Neurology Clinical Practice 2025, the take-home points, coprofenoema in patients who have more severe tics, often associated with comorbidities. Here they mention specifically ADHD, hyperactivity, impulsivity, and oppositional defiant sort of symptoms in young patients with Tourette's. And finally, the impact on global functioning and quality of life. Link with the quality of life that was already apparent when we conducted the study here in Birmingham, as I said, 13 years ago. 60 patients with Tourette's found that more patients had just the mental urges rather than the urges plus the actual swearing. And then there was evidence by the time the GTS score had already been published, so we could measure the impact on disease-specific health-related quality of life. No, we could document that people who had these symptoms had poorer quality of life. Okay, and finally, we also made a suggestion that there was a link between the presence of urges to utter obscene language and other urges of a similar nature, but related to non-obscene social inappropriate behaviors. So there's the idea that the spectrum of coprofenoema might be stretched to include also other social inappropriate behaviors which are not obscene, so which do not come under the umbrella of coprofenoema sensu stricto, strictly speaking. Okay. So this leads to the next point. I'll touch briefly on this, which is the NOSIBs, non-obscene social inappropriate behaviors. Because as we have just seen, they tend to go together with coprofenoema. And I introduce this with a personal anecdote. We go back in time 20 years ago. We are here in Birmingham, UK, not Birmingham, Alabama, Birmingham, UK. And I was giving a similar talk organized by Tourette's Action UK, actually. So there were patients in the audience sitting in first row and so on. The moment I opened my mouth and they started speaking with this crazy accent, of course, some people with tics from the first rows couldn't help but shout at me, non-obscene, these are not rude words, but someone might think socially inappropriate utterances, right? Which are clearly triggered by my accent. I like to think these were tics. I hope I'm not deluding myself. I've not been deluding myself for all these years. But this is a good example of what these non-obscene, socially inappropriate behaviors are. And I'm sure that you are familiar with this. Not much researched, because as we just seen, if there's any research, it tends to be about the coprofenoema, but very relevant. Another common example, commonly cited example of these non-obscene, socially inappropriate behaviors is feeling the urge to say, shout, bomb in an airport. So the least appropriate thing to do in that context, something that will get you into trouble. And you feel the urge just for it. Now, going back to my anecdotal experience, I was very pleased, I have to say. I tell this story to the students every year here at the Masters. We always have a laugh, so it's a nice memory. I wish they had mentioned more of the Italian stereotypes. Unfortunately, they stick to the basic ones. But I would have enjoyed a bit more of that, to be honest. What about this? Well, after this experience, after seeing this in clinic, we started regularly asking patients in clinic, not just about swearing, but also about this nosip. Then we conducted a study ourselves. We found, interestingly enough, a few patients who shared this particular complex tic, non-obscene, socially inappropriate behavior, pathological laughter, feeling the urge to laugh out loud where? Well, when it's socially inappropriate, a job interview at a funeral, things like that. Then with Mary Robertson, we contacted Jim Leckman from Yale, and he happened to have come across this in his long experience with patients with Tourette's. And so we wrote it up as a case series, London and Yale, of patients who all shared this particular non-obscene, socially inappropriate behavior. An early study from the 90s had already looked into these nosips, finding, again, interesting prevalence rates for the urge and for the actual behavior. You look at they sort of split the phenomenon into different components. They say some people might have had behaviors which involved insulting others. Some people might have had the urges to just make socially inappropriate comments, the anecdote I just mentioned, and some had to act on their urges to make these sort of socially inappropriate behaviors, so proper actions. And you see, if you look at the prevalence, they almost overlap with the prevalence figures for actual coprofenoema. So, and if we consider that they're often the same patients who have both, there's probably evidence for clinical subphenotype, a subgroup of patients with Tourette's who are more prone to develop both coprofenomenon and these nosips. And they also suggested the possibility of an explanation, a more general dysfunction of impulse control, subgroup with impulse discontrol playing key role in the pathophysiology. They developed a questionnaire. Again, in the interest of time, I don't read out loud all the items, but you can browse through the questions to get an idea what they were looking at. So starting with the actual coprofenomena and insults, and then the non-obscene, socially inappropriate comments, just the words, like the conference, and then the non-obscene, socially inappropriate actions, behaviors. And for each, they also look separately at the urge. So people feeling the need to do it, but managing to suppress the urge. Now, our study looked at that. The urges were quite common. 2/3 of the sample urges to make socially inappropriate remarks, so the comments, and or carry out actions. However, not all urges led to actions. Okay. Impact on quality of life, you see here, associated with significantly poorer quality of life. Yeah, social life, social interactions, affected, if not compromised by this. And then a link with higher tic severity, tic-related obsessive-compulsive symptoms, ADHD symptoms, and so on. Recently, 2 years ago, there was another study, again from the Polish group, about this nosib in Tourette syndrome. Prevalence, so these are the actual behaviors, okay, 23%, 24%. Age at onset, quite early, to say, surprisingly early, so even earlier than the actual coprophenomena. Already, you see, on average, 1.5 years after the onset of the first tic, some children in this case, can develop these non-obscene social inappropriate behaviors. Few examples from the more recent paper. They haven't changed much. So social inappropriate comments can be about physical appearance, accent, ethnic origin, the looks, these sort of things. Actions, I already mentioned the classic, you see, shout, fire, bomb, I have a gun in public spaces. There's more, also of a sexual nature. Number of my patients got into trouble at school because of this. This is debatable whether it's obscene or non-obscene, self-exposure. So again, genuinely perceived as involuntary, with regret straight afterwards, attempts at camouflaging, everything that you find also with Coprofenoema. It was a measure in the Polish study of the intensity, starting with just the urge until the actual behavior with major consequences. And the clinical correlates, see, statistical significance, tic severity, coprofenomena, and the most common comorbidities. The link between coprofenomena and these non-obscene social inappropriate behaviors is the alteration in social cognition. Okay, so they're all quite mysterious. We don't know why some people develop them, but there seems to be an alteration at the level of the network that subserves social cognition, what tells us whether a certain word or behavior is appropriate, adequate, or not in a given context, that aspect. I already mentioned that there seems to be, as we said, a subphenotype, so a subgroup of patients with these characteristics. And what about the underlying brain correlates? What can we say? The short answer is we don't know really where in the brain these symptoms arise in terms of which network dysfunction. We think it's about the social cognition network, but there is some evidence from other conditions. So brain pathologies, brain damage, brain pathologies that can result in a brain injury. In coprofenoema. The most famous patients in the whole of neuropsychiatry is Phineas Gage, described in 1848, actually, a few years before Gilles de la Tourette's paper. He was a honest, reliable miner who was working in the region of Vermont, Canada. And one day there was an accident, an explosion at the mine where he was working. An iron rod was propelled into the air, and it hit him, literally piercing his skull. Okay, he entered the skull through the orbit and exited the skull from the front of the brain. He didn't die, luckily. High risk of infections, dying because of complication, but he didn't. Still, he developed behavioral symptoms. His GP described him as a completely different person after the accident. And among his newly developed symptoms, there was also coprofenoema. You see, he had become, after the accident, fitful, irreverent, indulging at times in the grossest profanity, coprolalia, which was not previously his custom, manifesting but little deference for his fellows, impatient of restraint or advice when it conflicts with his desires. Now, I've been described that way many times, but the point is that he developed this after the prefrontal lobe damage, in particular orbitofrontal cortex. Okay, so there's a hint at a possible brain structure, if not brain network, that can result in this particular type of impulsive symptoms, impulsive behaviors. And his brain is still talking to us, preserved at the Harvard Medical School Museum. This is evidence of my humble pilgrimage to the rod and the skull of Phineas Gage, and most famously Antonio Damasio, professor of neurology at Iowa University, published the reconstruction of the trajectory of the bar in the brain, Science, in 1994. As I said, there are still papers being published about his actually type of lesion. Find a couple of examples here. And of course, similar cases have been described. You see brain injuries caused by metal rods or pipes, 12 published cases over the last 150 years. This is one example. It's a case of precipitation from a balcony, on a gate. And all these patients develop this type of behavioral impulsivity, often with coprofenoema, so prefrontal cortex, which again overlaps with this social cognition network that I've just mentioned. There's another example of someone who developed swearing, involuntary swearing, as a neuropsychiatric symptom following a brain pathology. In this case, it's a single case report of a patient with a temporal lobe epilepsy. It's a patient seen by the colleagues in Rome, and this is the letter with the documentation. So prefrontal and the temporal lobe might both be involved, which is not surprising. The prefrontal cerebral brake and the limbic system, which is a more temporal lobe regulating impulses and emotions, urges, the drives. To conclude, swearing as a tic has also been linked to important historical figures like Mozart. As you know, some colleagues argued that Mozart might have suffered from Tourette syndrome, and they based their claim on the number of swear words written by Mozart in his letters, which was far more than the swear words in the letters of his correspondence, his sister, his cousin, and so on. Okay, so evidence of coprographia. Does it mean that Mozart had Tourette's with coprolalia as well? Well, the answer is no, because in his biographies there are no mentions of actual tics, and even his swear words in writing production are more likely to be written jocularity. You see, this is Mozart's handwriting on his original script of music. He writes in Italian, the language of music. He says allegretto, ma non troppo presto, ma non troppo adagio, così così, con molto garbo ed espressione. So he's giving impossible instruction to the performer. This is the type of use of written words in Mozart, playing with words, including swear words. Whereas on the side of a consent form, one of our patients with Tourette also produced evidence, spontaneous evidence of writing, but this was more playing with the sounds of the letters than the actual meaning of the words. So even at the level of a writing production, people who have Tourette's seem to pay attention to different features of the words, okay? Mozart, intellectual playing with meaning, and tic-related sounds. The other famous character, Samuel Johnson, we know for sure that he did have Tourette's and tic-related OCD, but there's no evidence of swearing coprolalia. Okay, so if you want, the most famous people ever reported to have Tourette didn't actually have coprofenoema. And this was also acknowledged by the famous Oliver Sacks. You see, Mozart not convincing, Samuel Johnson entirely convincing, Dr. Johnson. I promised to just touch on functional tic-like behaviors, and I have to, because in these functional tics, functional coprophenomena are far more common than in Tourette's. First reported by Christos Ganos with Mark Edwards and Kirsten Müller-Fall before the pandemic, and then literally exploded during the COVID-19 pandemic. Look at the prevalence figures. Genuine Tourette's, coprolalia, 7%, functional tic-like behaviors, 56%. 4, 45, 20, 63. So it's, significantly more common, especially at onset, in patients who don't have Tourette's or other neurodevelopmental tics, but have functional tic-like behaviors. to the point that you see the presence of these frequent coprolalia or coprophenomena have been included in the diagnostic criteria for functional tic disorders to help the differential diagnosis between functional tics and Tourette's. Also in the European guidelines, you find that in the phenomenology criteria, there are vocal tic-like behaviors that include context-dependent and offensive words or statements. So especially there at onset in teenage years, more common in females, and disproportionately more complex and severe tics, including coprophenomena, rather than simple motor tics. And I'm sure you've heard about this. The reason for this increase of functional tics during the pandemic might have something to do with the increased exposure time to social media and influencers portraying themselves as having Tourette's and influencers portraying themselves as having a coprophenomena. No wonder they tend to attract more views, more likes, more popularity. Kirsten coined the term mass social media induced illness for these functional tic-like behaviors with coprophenomena, including the same swear words or rude gestures portrayed by the influencers. Okay, same type of words. Someone, based on this, imagined that Socrates was alive now, came back after, well, he was sentenced to death, and he killed himself drinking the poison, the hemlock, in 399 before Christ. Someone imagine he was alive now. He was shown the internet, and he was fascinated. Great, finally, you've invented a square and agora the size of the earth, where the best ideas can flourish. Then he takes a closer look at the content of the social media and says, do you happen to have any hemlock? I'd rather kill myself. Okay. We've reached the end of our journey. Treatment, it's a tic. When it's genuine, when we are good at the differential diagnosis, we treat it just like we treat the other tics. There are a couple of case reports, in particular, mentioning aripiprazole, which is first line treatment for tics in general. So nothing particularly shocking or remarkable there. Michelle said that this chat is timely, and she mentioned the movie, I Swear, and the BAFTA's incident. Of course, the movie, very well made, based on the documentary, BBC documentary on the real John Davidson, 1889. I recommend the documentary as well. If you can get hold of that, the original documentary, I use it. Lectures, for instance, with the MSc students. And again, some papers have been published since the I Swear film was out. Some people lamented the fact that too much stress was given to the swearing. Again, kind of fair portrayal, but always the kind of need to boost the media fascination with coprolalia by invariably portraying it every time we speak about Tourette. And of course, the incident at the BAFTAs where John was there, John Davidson was there, and he shouted the N-word. There were two black people on stage, a bit like what happened to myself, you know, and, in the lecture. They started shouting mafia, pizza, Mario, all that, spaghetti. And again, a couple of papers have been published just commenting on what happened at the BAFTA. There is a recent media coverage of the John Davidson Tics at the BAFTAs followed a familiar script, unfortunately. The focus now was attracted by the social inappropriate aspects, the swearing, and overlooking other aspects, including the pain that comes from living with tics, and in a way reinforcing kind of stigma that can be attached to this condition because of the skewed portrayal towards these more extreme manifestations. Just out another paper about the incident at the BAFTAs. Our ancestors would have laughed at us, especially if we think that some people were asked to apologize, for showing someone with Tourette having his symptoms. What's the problem? In Latin, the ancient Romans had clearly divided, the mens rea, the intention to offend, to harm, and the actus reus, the actual criminal behavior, the harm. If there's no mens rea, guilty mind, then there's no need to apologize. Okay, so in a way we've lost something with time, in terms of common sense and wisdom, right? I promised to leave the conflicts of interest at the very end, and well, being Italian myself, there's evidence that we like our swearing very much. We do, actually. Beautiful book, La Bella Lingua, by Diane Hayes, who is in love with Italian language, and she even likes Italian swear words, okay? You see, do Italians curse more than other people? Well, they do. They curse also differently. Italians express powerful emotions such as anger, disgust, surprise, and horror with sexual obscenities, rather than scatological ones. And then she details all the parolacce, the swear words in Italian, and she's delighted at these words. So, if I can suggest an idea, I wish I could. I would tell my patients, learn Italian, endorse the Italian swear words, endorse the Italian rude gestures as well. We are the people who use their hands the most when they communicate. We have a repertoire of copropraxia as well. And then just swear freely in Italian because that's cool. That's it. I think there's at least 5 minutes left for the questions.
Well, thank you very much, Andrea, for this not only interesting, but also very comprehensive presentation. Thank you. And yes, I think we would like to go into the question and answer session. And I would just like to shortly introduce our TTAG board member, María Belén Prieto, who is from Argentina, and she will be co-hosting the question and answer session. She also has lived experience, so I think she will be guided by the important questions at this point. And maybe we can even extend 5 minutes into the time, possibly. So, Belén, I'm handing over to you.
Thank you, Michelle. Thank you, Professor Cavanna, for such a clear and insightful presentation. This helps us break the common stereotype and understand the condition much better, so thank you. We have one question here in the chat and says, in neuropsychiatry research, coprolalia seems to be largely regarded as a binary outcome, presence-absence. To your knowledge, is there any research or plans to investigate the heterogeneity of coprolalia and how this is related to quality of life and other outcomes beyond just an examination of overall tic severity? For example, is quality of life or self-stigma correlated with ability to suppress coprolalia, frequency and intensity of coprolalia?
Very interesting question. Clearly, someone followed very carefully the presentation. Probably the question is better than any answer I can give to it, but I still try. I would say the urge to swear is probably the way forward, to conduct these sort of studies in people who not necessarily display the actual behaviors of coprolalia and so on, but they have felt the urge at some point, and they've either been successful at suppressing the urge, or the urge was not strong enough to, translate straight away into a behavior. So the answer is there's already something. The urge was captured in a couple of studies that I mentioned, but there's definitely need to do more studies on the urge.
Thank you, Dr. Cavanna. And we have another question. Jenna Scott says, if you can offer language for school admin to use if parents are calling the school to complain about tics that are racist or sexist and clearly don't see them as tics.
Yeah. It's all down to psychoeducation, really. We should be not just the patient, the family, but as much as possible, writing to the headmaster, to the teachers, to the carers, to all these people. And it's challenging for us as well, let's be honest, no, especially with the pandemic of functional tic-like behaviors. How many of these are genuine? How many? I think at the forthcoming European Tourette Syndrome Conference, there will be a debate about these coprofenoema. Are they genuine or not? Because there has been so many teenagers, no, who've developed them who don't have Tourette's, no. So, as I said, transparency, be honest with teachers. It's not easy for us, no, sometimes, but there are some red flags, no. If the child tries to camouflage, is clearly embarrassed by them, is regretful afterwards, displays this sort of apologetic behaviors, no, then it's far more likely to be genuine, of course, no, and so not to be blamed or penalized in any way for that, no, and try to work along these lines with therapists, with the teachers. Another thing that can be shared with them is the urge, no, train teachers as much as possible to ask questions about what was the driving force for the behavior. Was it the same physical need as the child reports for the eye blinking, the shoulder shrugging, or the grunting, sniffing, throat clearing, or is it a completely different sort of urge or need or impulse?
Thank you, Dr. Cavanna. And we have a last question from Elia. He says, grazie mille, Andrea, for a wonderful, informative, and also entertaining presentation. I would expect coprofenomena and nocive to be strongly associated with OCD. Can you speak to any findings on this from the literature?
Well, thank you, Elia. And the answer is yes. Some of the studies did find the association also with tic-related OCD. Broadly speaking, I don't know what's your experience, but in clinic, we tend to see patients with Tourette's can be classified according to the comorbidities into two broad groups. One is Tourette's, so tics plus tic-related OCD plus anxiety plus these kind of symptoms and behaviors. And the other type are the more impulsive ones. So they share the tics, but they tend to be at the other end of the spectrum with ADHD, impulsivity, sometimes oppositional defiant, challenging behaviors, and so on. And according to the studies, these coprophenomena have been associated with either group, okay? So again, it might be that we need to differentiate between different types of coprophenomena and nocive and situations when they come up, and maybe the different types can correlate with one group rather than the other. So with the OCD group rather than the more impulsive. I'm just, brainstorming here.
Thank you, Dr. Cavanna. Michelle, I don't know if we have time for another question or here at the chat.
Well, our official time actually it has ended, but may I ask, Andrea, would you be willing to stay on a maximum 5 minutes to maybe answer one or two more questions? That would be wonderful.
Sure.
Wonderful. Thank you very much.
Thank you. Dr. Cavanna, Renacito says, the talk was titled Debunking the Stigma of Coprofenomena. Much of the talk focuses on prevalence and correlates of coprofenoema, as well as acknowledging the impact of the BAFTA's incident. What do you see as the best strategies for reducing the stigma of coprolalia itself?
Yeah. Take-home message should be in the Latin slides. So education, yourself and the people around you, as much as possible. Once you are educated to the level our ancestors were, the stigma disappears. Okay? Because they see that that is just an involuntary symptom. So stupid, to use that to devalue the other person. Immediately you start seeing the person as it is. You see through the tics, you see through the coprofenoema, you see the person, the human being who is in front of you. My take is that, and that's what or what's within my control, try to do as much as I can. Educate myself first.
Thank you, Doctor. May I ask you one last question, please? Your presentation references the recent rise of functional tics-like behaviors in 2021. Given the high prevalence of coprofenomena in these TikTok era cases compared to the traditional 10% inorganic shields de la Tourette, what are the key red flags you use to differentiate a functional tic-like behavior from a late onset Tourette presentation during a consultation?
Yeah, number of things. No, some are in the history. So, is it acute onset or subacute onset? So from 0 to frequent, complex tic-like behaviors within days or weeks, functional, rather than gradual development through the years. Then, as we know, the genuine neurodevelopmental tics. So some are in the history. Some are in the actual phenomenology. As we said, when in genuine Tourette syndrome we have coprofenomena, they tend to be on top of on a base of already severe tics. So there are already a number of simple tics, frequent and impairing, and then on top of that there might be the coprofenomena. When we see the opposite, striking coprofenomena, non-obscene social inappropriate behaviors in the absence or in the scarcity, paucity of simple eye blinking, mouth pulling, shoulder shrugging, or simple vocal tics, grunting, sniffing, throat cleaning, that is another red flag. So it suggests the disproportion indicates, again, functional etiology. And other features can be the context. When are these behaviors produced? Okay. If they are selectively produced during the consultation, on screen, when, again, a big red flag. No. As we know, neurodevelopmental tics in Tourette tend to be there baseline anyway. They can get worse in certain situations, yes, but nevertheless, they are quite constant in the background. I just mentioned a few of the things. There's more to it.
Thank you. Thank you, Dr. Cavanna. Michele, I give the word to you.
Yes, thank you. Well, we greatly appreciate your expertise and your presentation, Professor Cavanna. It's been a pleasure to have you here. And thank you not only to our speaker, but also to María Belén for hosting the question and answer session, but also to our audience for their interest in our topic and also in our umbrella organization. So thank you and have a wonderful day, evening, wherever you are. Thank you very much.
Many thanks. Bye-bye.
Bye-bye.